He had what I now learned was his first psychotic break, and it was really scary. When he went into the psych emerge, the staff wouldn't share with me what was happening with him at a time when I had no idea, and I was so afraid.
So what we just heard was a mother describing what it's like to be kept out of her son's care. We know that privacy laws exist for a very important reason. They're meant to protect a person's dignity, autonomy, and personal health information. And they also exist to protect vulnerable individuals when a loved one is not well. So where does privacy end? And where does care and safety begin? I'm Faydra Aldridge. I'm the host of Look Again, Mental Illness Reexamined, brought to you by the BC Schizophrenia Society, or BCSS, and other BC partner organizations. This is Look Again, and I'm your host, Faydra Aldridge. Today we're exploring the information gap that some families experience when supporting someone they love with a serious and persistent mental illness, and why accessing medical information can be so difficult at times, even when families are legally recognized. Now you're going to hear about Monica and Braden. She's a mother and the legal representative of her son Braden, who lives with a severe and persistent mental illness. For more than a decade, Monica has supported Braden. She's helped him find housing, navigated treatment, and she's been directly involved with his care. Monica and Braden have formal representation agreements in place. Now, these are legal documents that allow her to access information and to help make decisions when Braden is not able to make those decisions for himself. But as Monica shares, even though she has these documents, they have not always helped her. During Braden's hospitalizations, despite her legal role and her involvement, Monica has been denied important information to her son's care. What we're about to hear is a very personal and deep conversation. It's about love, it's about autonomy, it's about advocacy, and the sometimes very difficult tension between autonomy and safety. Here's my conversation with Monica. Just so glad you're here. So let's talk about your son, Braden. I'd love to hear about him.
Well, already that brings tears to my eyes, because that question rarely gets asked, Faydra. Who my son is. I'd say he's just one of the most sort of generous beings that I've met, had the privilege to meet, and just really compassionate in so many ways. But what really inspires me, that is so I'm so awestruck by, is his resilience. And I want to use that word because he's been through so many hardships and so much suffering. He's currently in the forensic hospital. He finds purpose by helping other patients or supporting other patients. I could go on, but I think the other thing that I just love about him is his vulnerability. I'm proud to be his mom. So to see him suffering in this way is hard.
Monica, thank you for giving us some insight into your son. And I understand that you, as his mother, were cut out of Braden's care from his very first hospitalization, even though he was clearly incapable of making informed decisions and providing informed consent. Can you please give us an overview of what that was like and what you experienced as a mother trying to protect your son?
When he was 22 years old, I didn't know what was going on for him. I mean, he had what I now learned was his first psychotic break, and it was really scary. When he went into the psych emerge at that point, there was this sudden block of, you don't have consent. The staff wouldn't share with me what was happening with him at a time when I had no idea, and I was so afraid. So And I just couldn't understand that. My experience in hospitals, usually when if something happens to your child, you're in there, no one questions, and the doctors share with you. There's some staff that will share, and then others won't. But when I look at it from a trauma-informed lens, I'm also traumatized in this too. So where is the recognition that in a place of fear as well? And there's things that I think staff can do to just help alleviate that, so they don't really end up with two patients in the end.
I think that's a very good point, Monica, that there's two parts to this. There's what your son is experiencing, but there's also what you are experiencing as a parent, as a mother who loves your child and would do absolutely anything for him. Some psychiatrists and some clinicians are very good with sharing information, but it sounds like your experience, you haven't met with a lot of those clinicians that are openly willing to share the minimum amount of information regarding your son. Could you please just tell us a little bit more about your experience in that area?
Yeah, I mean, all honesty, it's very rare that the sharing is there. It's me giving information because I feel they need to know this information. I have information about his brain injuries, about his medication tolerances. I'm the one that can really best assess his capacity and his insight, because it varies. So my experience is that it's not a two-way street where I am being asked or I am being engaged. What it is me, putting it out there. And now I've learned over time, after seeing his medical records, that most of they call it collateral evidence that I provide, and the things I provide does not show up in his records. So each admission, and there have been many, it's like I'm repeating myself. His history is not brought forward in his medical records. And that's deeply disturbing to me, because he's had some very severe, almost life-threatening reactions to his medications. And I worry that if I'm not there to be constantly reminding and reminding, that something can seriously happen to him. And so that is really concerning to me. I read the policies, PHS policies, about the importance of the circle of care and family and patients part of it. It's not my experience. I want him in the hospital when he needs to be in the hospital, but I also want him out of the hospital when I think he's ready to come out.
And I even understand, Monica, that you have legal representation documents, Section 9, Section 7, enduring power of attorney. So, why do you think, despite the fact that you do have legal representation, that your experience, these were not taken into consideration?
I have every legal document available at this point, other than becoming his guardian and a comité, which my son said he would do. So it's scary to me that I can have all of the legal documents available. And my son wanted this to write an affidavit to basically say that I cannot revoke these agreements as long as I am in involuntary treatment or in a care in a hospital under certain conditions. He may get so unwell, and it has happened, that he will withdraw consent. And at that point, the hospital won't release any information, won't tell me what's going on for him. But that is precisely the time that my son needs his representative. He doesn't need me to have his representation agreement when he's well enough to engage me. My son and I had a safety plan to say, Mom, if you don't hear from me for a few days, then there's something terribly wrong. And that's when I need your help. That was our plan. And that happened. And then, and that point, there was six weeks at least where I didn't hear from him. And the hospital would not tell me anything that was going on for him, where he was. And only a few months before he had a very severe life-threatening reaction to his medication, was rushed into emergency. So I was really, and I knew there were medication changes happening, and I knew there was something terribly wrong. And I would say that was the most difficult time in these 11 years, to not know, not even being told what unit my son is in, how he's doing, not allowing the release of documents, which totally my representation agreement says I have a right to, and so that I couldn't look into his medications, fearing that he would have another adverse reaction to his medications. We are a real team together. His safety depends on it.
And provincial legislation will allow the sharing of information and the release of personal information to family members, to other third parties, healthcare professionals, etc., that are involved in a client's care for the purposes of that care, as long as it's in the best interest of the patient.
Yeah.
Some families are told by some clinicians that they can't share information due to privacy laws. We know the important role that family members play in the care of a loved one. So I'm curious, based on your experience, how did privacy barriers affect your ability to keep your son safe during a crisis?
Early this year, my son was in seclusion for weeks and weeks on end and suffering. And I now am looking at his medications that he was on. From my experience over the years, there's no way that he could have been stable on those medications that he was on. I believe kept my son in seclusion. Now, I consider seclusion as treatment failure. That's the way I look at seclusion. So to me, when my son is in seclusion, that means more involvement in looking at what's going on for him. What's what the medication? Is there a trauma situation? Is he not feeling safe in his environment? All of those things would be considered in that case. So I believe that my son suffered immensely and is going to suffer a long time in his life trying to recover from the trauma of that experience, and also not having, the support. Like, now he's really angry. He's not trusting the staff at the hospital at this point.
And especially because he had established already that you two were a team and that
Yes.
he wanted you involved. And we both know that an individual experiencing psychosis will go up and down. Now, something that we've talked about before is anosognosia. Anosognosia, as we know, is an inability to recognize you are ill, which happens to the majority of individuals with schizophrenia and experiencing other psychotic disorders. So I'm curious about your experience with anosognosia. Does he experience it?
Oh, I know it well. When there's the certain progression, there gets to be a point when he does have, call it losing insight. I think it's more than losing insight, but he's unaware that he's unwell. And it's actually almost too late for the treatment, because then it becomes a safety containment issue. And the problem I see with the way the system works is you can't really get help until he is in danger to himself or others. He needs to get the care before we hit the switch of when he no longer can make real rational decisions. And these are decisions that can really affect his life, like taking a substance on the street, not knowing what it is, or walking into traffic. The problem isn't the seeing it coming. The problem is getting the intervention when you need it. And that's been my role over the years, is to help with that. If I was listened to as a representative early and saying, my son is actually, we've got a short window here, he's going to need some help now, when he can still recognize too, and he can get the help, we could prevent. And I honestly believe that all the consequences that he has faced now were all preventable. So there is also a real serious problem with the Section 9 representation agreement. And the Section 9 representation agreement is the one you execute with a lawyer. The problem with that particular representation agreement is it requires the establishment of capacity to be enacted. It assumes that the person has capacity unless there is a medical determination that the person lacks capacity. Well, when you look at it from the perspective of anosognosia, who is going to go into a doctor to be deemed incapable when they're in that state? It's a absolutely useless representation agreement over the years, because I have tried to use it He's not, and it says in his agreement, his family physician has to assess him. It's usually a physician to have lacking capacity before all of a sudden that agreement comes into play. Well, that's not going to happen. I've tried it. It will not happen. I'm not going to get him into, first off, his family physician he hasn't seen in years. I'm not going to be able to take him to his psychiatrist if he's, his insight is gone. So you might as well throw that agreement out. It's useless. It cannot be used. So that's when the Section 7 representation agreement is more useful, because the Section 7 agreement is in effect. It doesn't require the capacity assessment. So that allows a person to have a representative when, at all times. The problem with that agreement, it can be easily revoked. I don't want one today. So it's done. It's over.
Yeah. And I realize we're talking about your experience, but we've also heard you're not alone. So what do you think we can do, whether it be family members, community organizations, even clinicians? What do you think we can do to improve our system if you had that magic wand?
So I ponder this a lot. We know what the problem is. We actually need to take this to the courts, and an actual situation of being denied the use of the representation agreement, and get the judicial system involved and we need to advocate with the College of Physicians themselves. There needs to be some kind of consequences for denying.
I guess the quote unquote counter argument is the importance of the doctor and patient privacy. So I would love to hear your thoughts when people say an individual has the right to share or not share with a loved one.
I think absolutely they have the right to share or not share with their loved ones when they're in a mind state where they're capable of making that decision and they know the impact of that decision. But when my son is not at that place where he knows the consequences of what that means for him, that will cut off. I don't want to be in conflict. My desire is for my son to get well, to get out of the hospital, to have his life back. And I will do anything to help that. And I will work with any doctor, with anyone.
We know that research consistently shows the benefits of having family involvement. So, Monica, thank you so much for being here today. Thank you for your vulnerability and for sharing your story and for providing a little more insight into a very important topic that more and more families are speaking out about.
Yeah, thank you for having me.
Now, before we move on, I think it's important to pause. We have to remember that this is not only Monica's story, that Braden is a key person in this conversation. And Braden has allowed us to share with you a conversation that he recently had with his mother. Let's take a listen now.
We've been journeying together for the past, 11 years or so, since you were first diagnosed. What has it meant to you to have me be your representative?
Well, it's helped me immensely because I didn't have the support I needed without having you on this journey, and I feel like I would have really went off the rails. You provided me with housing, you provided me with endless opportunities to enhance my future.
I mean, it's different from when you're living in the community and then when you're in the hospital. Right now, you're in the hospital. What role do you see me playing with you being sort of involuntary in a hospital right now?
Well, realistically, the role is being taken for granted right now, and I'm a little bit frustrated at it because you should have more power and say than what you do. And right now, I need help because my mental and cognitive abilities have been diminished in recent history, and I know that I need further support. And right now, I could really use help with my treatment and care and advocacy, and right now that's what you're providing me with. But I feel like you need some more support from their end. I'm all alone in here. My treatment team doesn't know me, and you know me better than anyone. I feel like there's not a whole lot I can do from inside of here that without the support from the outside and without someone kind of almost guiding me in a sense, because they kind of do whatever they want in here as far as the treatment goes. You feel very powerless.
And in terms of them having denied me access to your records, do you think that was in your best interests?
No, that was really hampered my ability to get well.
When you withdraw consent, in order to maintain their sort of therapeutic relationship with you, they need to make sure they're listening to what you're saying. How do you feel about that?
Yeah, but I just wish they had someone that could judge capacity properly. When I'm locked up in a side room completely out of my mind based on the pharmaceuticals they've been giving me, I just feel like there maybe needs to be someone that can make that judgment call properly. I just wish there was someone who was in my corner and being like, wow, he's not very well right now. Why would he be wanting to withdraw from his mother? Because you can make decisions for me when I'm incapable of making them for myself, and when I'm capable of making them for myself.
I just appreciate your trust.
Yeah, thank you, and I appreciate you trusting in me and you supporting me to the utmost extent. I don't know where I'd be without you today, and it's been so amazing being able to just call you and have someone who cares on the other line. I've been very lonely and been really struggling with my anxiety, so thank you for that.
Yeah, I love you, Braden, and I'm here for you. I love you, sweetie.
Okay, I love you, Mom. Thank you.
So Braden's description about what it feels like to be in hospital adds a very important perspective. Him feeling alone and knowing that the person who means the most to him in this entire world is not allowed to be a part of his care is a really important conversation to have, but it's also really difficult to hear. Monica and Braden's experiences raise a very critical question. Why is the gap between families and care team seem to be getting larger? And to give us more information, we now turn to Dr. Richard O'Reilly. Dr. O'Reilly is a psychiatrist who has worked for decades in inpatient mental health settings. He's written and spoken widely about privacy legislation, family involvement, and what happens when families are not involved. In this segment, borrowed from a virtual town hall hosted by BCSS and the Family Alliance on Severe Mental Illness last year, Dr. O'Reilly is going to explain why the issue isn't necessarily the law itself, but how it's interpreted and how it's applied. Here's Dr. O'Reilly.
It's an issue, a problem that's pervasive and runs through the culture of mental health services and of mental health service providers. Here's an important thing that's I want to say to you. In my opinion, the privacy legislation across Canada is reasonably adequate for the purposes that it's designed for. And they're really to protect the privacy of our healthcare information. But also, another purpose is to allow clinicians to breach that duty of confidentiality in certain situations. Now, for sure, it's the legislation might be improved by changing wording here and there in some of our provincial and territorial acts. But clinicians don't use the current legislation, which is, in my view, reasonably permissive to share information appropriately with families. So changing a few words in legislation without changing the culture will not rectify this situation. So I'm just going to briefly talk about the first three. So all Canadian jurisdictions allow clinicians to contact people apart from the patient, him or herself, to collect information when that information is needed for clinical care and it is not possible to get the information in a timely fashion from the patient, or it's not possible to obtain accurate information from the patient. So that's when clinicians can obtain information without consent. All Canadian jurisdictions allow clinicians to provide information to others to prevent serious harm. So if there's a risk of serious harm, clinicians can provide information. And harm, serious harm, is defined differently in different jurisdictions. I think it's really important people read that part of the legislation and say it's too restrictive, but it's specifically to prevent harm occurring to others. And it actually legalizes what is already in the common law. And then finally, most jurisdictions, BC being one of the notable exceptions, recognizes in legislation that adult patients may be incapable of consenting to the release or incapable of preventing the release of their healthcare information. And those jurisdictions then have a system to deal with that, to allow information to be released where necessary. So if this legislation is there, why do clinicians regularly fail to use these provisions to appropriately collect and disclose information? I want to start with a positive one. It sounds a bit like an excuse, but I think it's important for this group to keep it in mind because we can easily get indignant, and I think there's all sorts of reasons to be indignant, but it's important to understand the clinician's perspective. So I'm going to really emphasize how important it is to keep information confidential between a doctor and a patient. That's the sort of starting point. And then exceptions have to be well defined. And this shouldn't be just dismissed. And it's especially important in psychiatry, where patients often share highly personal information with clinicians. So, even in situations where the law allows a psychiatrist to share information, that psychiatrist may decide that such approach would damage the doctor-patient relationship and not be the appropriate course of action. However, I'm immediately going to say that this is not the majority of the cases. It's a small minority of cases. So what are the other reasons? Well, one clearly is ignorance. And I know this is going to surprise people, but many clinicians, including psychiatrists, are unaware of the provisions in their privacy legislation. So then where do clinicians get their information? Well, clinicians almost exclusively hear messages from their superiors, clinical superiors in hospitals or agencies they work for. And it's all to like every single issue that's brought up is about situations where I'm prohibited from sharing information, not one where I must or should share information. It's time consuming to involve families in care. I know this is a practical issue. It's important, but it shouldn't be the primary driver of clinician behavior. But there still is an anti-family bias in our system. It goes back decades. We talked about in the past about the schizophrenic mother. More recently, people follow these things. There's a lot of issues about trauma in patients with psychosis and implications directly or covertly that this might be because of family issues. So again, families are seen as potential problem, part of the problem, not the solution. And alas, the first thing I have to tell you is that there's no easy answer. To change the culture, we really need to pressure professional colleges to get their members to follow the law. And then we need to convince the clinical teaching schools to emphasize the importance of including families and to emphasize the legal authority to do so in certain situations. And we must convince hospitals to deliver a more balanced message. The final thing I want to say is that complaining it can be done effectively, and it is effective if 2 or 3 people complain about the same thing to a hospital, not being the psychiatrist in chief of a hospital, then the hospital will sit up and take note.
To watch the entire town hall on patient privacy and information sharing with Dr. O'Reilly, please visit the BCSS YouTube channel or check out the links in this episode's description. Evidence consistently shows the importance of having family involvement. It not only helps the individual living with the illness, but also on our overworked and overburdened clinicians and healthcare teams, as well as the system overall. We have to keep finding ways to bridge this gap and find ways for health professionals and family members to build a stronger circle of care. We know the importance of this, but what can we do? Well, there's a few things. We can ensure that frontline teams have sufficient and current training around privacy legislation. We can push for increased inclusion of family caregivers in the development of mental health programs, and we can address the outdated family blaming and mother blaming that is still extremely prevalent in our society today when it comes to serious mental illness. And we can keep talking about it. If today's episode resonated with you, and I hope it did, if you're looking for more information, more resources, please visit bcss.org. And remember, together we can help each other. Together we can make an impact. And together we are stronger than stigma. I'm Faydra Aldridge. Thank you so much for being here, and thanks for listening.
Look Again is produced by Paula Baker at JAR Podcast Solutions and executive produced by Faydra Aldridge and Miles Constable for BCSS. It's brought to you by the BC Partners for Mental Health and Substance Use Information, a group of nonprofit organizations providing high-quality mental health resources to help individuals or families maintain or improve their mental well-being. For more information you can trust, please visit heretohelp.bc.ca. This podcast is funded and stewarded by BC Mental Health and Substance Use Services, an agency of the Provincial Health Services Authority.